So excited for our grand rounds today. We have Emily Anderson with us, who is the program controller and manager for the Kentucky Department for Public Health. And so she's going to talk about tuberculosis across the state of Kentucky. So Emily, I hand it over to you. I'm going to turn off my camera and you should have full control of the screen.
Fantastic. Thanks, Julia. Once again, it is so great to be back here with everyone. I'm getting ready to share my screen. Make sure I've got it here. Takes just a second. All right. So a short time I have with you all today, but it sounds like there's going to be some more opportunities for us to join you all and give some good updates. But today, just want to focus a little bit on some of these objectives. We're going to always give you some data, what's going on in our state as far as TB in the Kentucky compared to US. We've got some new stats that we just learned about in the last hour that we're going to be updating soon. We're also going to talk about some of our regulations regarding reporting, treatment, employee testing, and preventing TB in Kentucky. We're going to identify some improvement and future directions important in continuing reduction of cases and transmission in communities across the state.
Emily?
So here's, yes, ma'am.
Before you get started, we are seeing your notes screen. So,
oh,
I
okay.
think we might.
Oh, I forgot to. That's right. I forgot to. Let me just stop sharing that for 1 second and get to the presentation. There we go. And well, shoot. Sorry about that, everyone.
No problem.
Appreciate you stopping me. And presentation mode. Or oh goodness. For objectives, here's our beautiful state and all of our beautiful counties that have been color coordinated to show, where we have more than 20 confirmed cases in our state. So you can kind of see that there are just some selected counties. And why is that? This nice peachy color, that's usually where we have, of course, our highest population in the state. And then also we have some immigrant and refugee resettlement areas in the state there. We are one of the non-border states in the United States that has a high population of immigrant and refugees coming here due to our wonderful industries that we have and our farming and our we have produce, chicken produce facilities in the state, construction, then our horse farming, of course, our horse racing industry also. So it's just so many great opportunities to come to Kentucky. But we can see that this was our most updated information from 2022. However, even though we have those nice states there, or excuse me, counties with the highest incidence, TB can occur anywhere in our state. And so we often have suspected cases throughout the states that we are ruling out at any given time. And sometimes it takes 6 weeks to rule those individuals out. Most likely they could end up being cancer, or a non-tuberculous mycobacterium or an NTM. And so we're ruling those individuals out. So it's a very busy time in the state, even though some of our cases may seem a little low to other states. Here is our race and ethnicity. You're usually seeing most of our cases that non-Hispanic Asian, followed by non-Hispanic Black, and non-Hispanic White being kind of the lowest in Kentucky. And again, it's a lot of that industry that is happening in Kentucky that has those individuals. U.S. born versus non-U.S. born. about 61% is our non-US born of our cases, 39% being US born. And of those, Mexico tends to be the greatest country where we see cases in Kentucky originating from. Of course, other would be 43%. That could be any country in the world where we have one case from Micronesia, for instance, or Guatemala, or but we have a little bit more from Guatemala recently. But you can see here, these are the most prominent countries where we will see individuals in our state. I want to point out real quick, give a shout out to our webpage, and we do have a regulation toolkit available since 2016, and it has the most frequent healthcare regulations pertaining to TB, and that would be the two that I'm going to focus on, or the one I'm really going to focus on today, and that's our regulation for healthcare workers. But just know you can go directly to our webpage anytime and get those regs. And the two that we have the most questions about are the regulation for healthcare worker and reportable disease surveillance, meaning you got to report. So let's start with that one. And that is 902 KAR 2020, and particularly Section 6. And that is where these are the notifiable conditions that need to be reported within 1 business day. And what do you report? What constitutes what you must report would be acid-fast bacilli, a positive sputum smear, for instance, because that means, that's a very early precursor of could this actually be active TB disease. TB signs and symptoms, which can also mimic many other conditions. So we got to kind of look at the symptoms as being one of the first precursors coming into your EDs. And then also your PCRs, or particularly the TB gene expert. So if you have a positive result from a PCR, and of course the gold standard would be positive culture. Now, positive culture can happen anytime within that 6-week time frame where you're monitoring those cultures. And sometimes a positive culture is going to be a late indicator for you to report, but you still need to report that. The earliest would actually be that AFB sputum smear or those signs and symptoms of that patient, and of course the risk factors surrounded by that. Section 2.5b, again, you shall furnish clinical, epidemiologic, laboratory confirmation pertinent to that disease, including the sources of specimens. So we need to know where that specimen, was it a bronch, was it an induced sputum, or was it tissue or fluid? That's what we need to know. And then Section 12, in healthcare associated infections, and also with HIPAA, we get a lot of questions coming back to us about, can I share this information? Can I share the patient's records? Yes, because HIPAA in that Accountability Act, it does say that public health information is shareable without the patient's consent. So just know that in that Portability Act, that Portability and Accountability Act, that it does authorize you to share that information directly to your local health department and state health department. Okay, we preserve all patient confidentiality, as does our local health departments, because we do share information directly with CDC, and we have to evaluate all HAI data and for accuracy and completeness. So just know you are covered and need to share that, and it's very, very helpful if you share this information with your medical records department, because most often we will have some patients transfer out of state or coming into our state, and we have to share those records state to state. And sometimes what will happen is we'll request that information from your medical records department or health information department, and they'll say we need the patient's uh, um, approval, consent to do that. Well, again, it's public health information, and we do need that information, and they can share it without that. So just know that if you can help get that information to them, because time is of the essence when it comes to TB, and diagnosing, starting medications, and getting that patient out of airborne infection isolation. So also, um, like I just said, you have in the reporting regulations, it's saying that you have to report within 1 business day. So an employee that has been exposed or has a TST or blood assay conversion on annual testing, if there's someone that's being annually tested, that needs to be reported. So, or if you have identified an individual in a contact investigation after TB exposure. Now, notice that I've not said that you let that employee know first and that you start doing a contact investigation within your facility. We'll get to that. But what you do have to do is notify the local health department or the state health department that there has been some known exposure. And then either one of our state or local departments will help guide you in your next steps. Do you go ahead and start testing your employees or what? But what is the next step after determining that there has been TB infection indicated on a result, either skin test or blood assay? The next step is a chest x-ray. And then, particularly if that chest x-ray has some abnormalities, the next step would be collecting sputum. And that's all, again, something that we or the local health department, particularly Louisville Metro Health Department for you all, would help guide you in what those next steps should be and when or if they would occur. And I just went over this again, just talking about some of those testing and those results that have to be reported. And that's that PCR, the culture, or most often too, if you are initiating treatment, we hope that you're not until we get a PCR, we get some sputum. We hope your providers are not starting treatment until we can get some raw sputum to be tested, particularly even for Gene Expert or even to our state lab. And why is that important? We want to make sure that we're starting the correct drugs, that your providers have immediate information on if there's a rifampin resistance from the Gene Expert testing, if they can detect that mutation, and we can easily then guide the providers in starting the correct medication treatment. So that's why all of this collaboration very, very early is so important, so that we make sure that we're giving the best treatment to our patients so that they optimally can get better sooner. So also in that regulation 205 is that you're going to report within 5 business days that employee that has had a conversion on their skin testing or their blood testing. And that would be either initial employment testing or those that are tested annually in those high risk for exposure areas of your facility. Also, we in 2015 enhanced regulation in that 220 that pharmacies in Kentucky must report, and that's any pharmacy, whether it's a commercial pharmacy, a healthcare facility pharmacy, but that's very, very important that if 2 or more known TB medications are prescribed, that must be reported to the local health department. And why is that? We want to make sure that we're catching any potential suspected case or already diagnosed case that somehow didn't get reported. So it's a backup method. And then also with that reporting, we want to make sure that the correct dosages, again, are being reported, or excuse me, are being prescribed, because there is a standard care of treatment for TB. It's a 4-drug chemotherapy treatment. 2 drugs are weight-based, 2 drugs are not. There's a standard dose that we want to start on individuals, and that includes even for children. So it's very important that that patient, again, is receiving the most optimal treatment in the very beginning. All right, so there's our little friend. If you've been with me before, you'll know that our little mascot is the Super T Bug, and he's going to join us along here, make it just a little fun and not so uh, staunch in our discussion. But we're going to hit that regulation and some of the most frequently asked questions, and he's going to help us along here. So in section 2 of the regulation for testing for healthcare workers, that is where we state that your facility gets to determine who is going to be annually tested. And how do you do that? You look for the areas in your facility that have the greatest risk for TB exposure. And that's usually your EDs, your bronch suites, and any other area of your facility that you think that you are potentially going to have exposure, that greatest risk. And in your infection control plan, you're going to list those job series that have the greatest exposure and state that you're going to test them. It also describes in section 2 new employee testing and testing on exposure. Is a facility risk assessment required? This is a frequent question that we're getting across the state right now. Usually this question comes in the spring, so it's a little odd that it's coming in the fall this year. But OSHA regulations do state that you have to have a facility risk assessment completed. CDC does not require it. We do not require it from the state program, so know that this is an OSHA requirement. However, CDC back in 2005 actually developed a nice little template and a form that you complete. And section 1 of that form is asking you, what are your average case rate in your jurisdiction? Is there a high risk of TB in your area? We provide all the data that you need on our TB website annually. And TB data is a little different in that, because treatment of TB can be 6 to 9 months, sometimes even longer. And so data is really not finalized for 2 years. However, we also put preliminary data of the current calendar year on our website, and you are most welcome to use that. So just know, when you go to our website, it is the most recent data that you would need to complete your risk assessment for your facility. But we also ask that you also look at some of the other indicators to help determine that risk. What is not only how many cases, active cases, have you had at your facility in the last year, but in your jurisdiction. So if your facility may not have had a case, but have there been cases in your jurisdiction in Jefferson County? Oh, yes, as they are our highest incidence in the state. So you may be treating at any time someone that has active TB, and it may not that you did in that year, but guarantee you will be at some point. So we also ask that you look at the surrounding counties to see what their TB incidence is also, because if you're admitting patients from Bullitt, from Shelby, from Owen County, from any of those surrounding counties, you've got to really kind of get a good idea of what's happening TB wise in those counties also. Okay. So is annual testing required? I just mentioned that it's your decision. your facility's decision, right? So it does require testing on hire for your new hires. However, there's some exclusions there also. And then also those individuals that have the greatest risk for TB exposure, those job series need to be listed in that infection control plan. And those are the individuals that you will test annually. So no, you do not have to annually test every single healthcare worker or those ancillary job series, volunteers, those contract workers that are coming in. So take a look at that in section 2. And what's included in your infection control plan, that's going to be the identification of all those job series and those individuals that have to have the annual testing. Now, I know I keep repeating myself, but that's because it's very, you got to get down into the weeds in those regulations sometimes, and it's hard to kind of interpret everything that you're supposed to do. So I just always want to repeat that for you. Is a two-step TST done for both initial hire and annual testing. Two-step testing is useful only in the initial skin testing of anyone 2 years old and above who are going to be retested periodically. That's your serial testing. And those are usually your healthcare workers that only do the two-step method, and that's on hire. Okay, that's not going to be annual testing at all. And of course, a blood assay is only one draw, so there's never that second test. However, when we start talking about retesting, that comes into play when we're talking about contact investigations, because it does take 8 to 10 weeks to mount a response after exposure. And so sometimes we will be saying you need to be retested again if you're involved in a contact investigation. So two-step testing only on hire. Okay, I like this little algorithm because it is helpful to kind of know for that baseline skin testing. And yes, we do have skin testing being done in some of our smaller healthcare facilities across the state. It's up to you which method you want to use. We highly encourage, though, for the larger healthcare facilities such as yourself to use blood assays. Most popular is the QuantiFERON Gold Plus now in Kentucky. And why is that? You don't have to bring them back for the second step, number one. And if they get out of sync with the days and everything, you don't have to start over. You just do one blood draw and you're done. So that's why it's much more convenient and much more accurate, because a skin test, it does have that subjective reading. And if you are a novice at administering a skin test or reading a skin test, you may read it inaccurately. So again, that's why we highly promote in large healthcare facilities that they use blood assay testing. So with the skin test, you're going to look for that reaction. Is it a positive reaction? They probably have TB infection. So retest is not necessary. You don't have to do that second step. If they are a known or must have documentation, if they say I've been a previous past positive, then you don't even have to test. Okay. If they do not have documentation, you've got to create a new baseline for that individual. All right. So the key there is documentation always. If it's negative, you're going to retest 1 to 3 weeks later. And if there's a reaction, if it's a negative reaction, they don't have infection. You may retest at regular intervals. And always that's talking about if you're retesting that individual annually. And then they may have a positive reaction, and that's a recent exposure. You know that then. If they have that positive reaction, you can consider that a boosted reaction, and retest it is not necessary also. So this is just a really good little algorithm in talking about how to determine if you're going to test or retest in that initial hire again. So how should I determine when to begin staggered testing for each employee? Um, so staggered testing increases opportunities for early recognition of infection control problems that can lead to conversions in test results. So we CDC recommends staggered testing so that you're not always testing everybody every June, for instance, when you're doing annual competencies or something, but you need to pick a time period. It can be higher date, higher month. It can be that you test everyone in the ED on every June or something, but you can choose when you're going to stagger that testing. It does not matter to us, just as long as you do. And again, that helps in contact investigations and determining, was this a new infection or is this an old infection that we haven't tested for in a while? So staggered testing is up to you in the facility. And when is a new hire exempt for a TST two-step testing? And this again, that regulation in section 3 can be a little confusing. It's a long section, and section 4 is a long testing, also is a long section also. But anyone that has a test result initially, and they have documentation that they have had that test result within the last 3 months, they do not need to be retested. You can on new hire, that you can accept that result and you're done. If it has been longer than 3 months and less than 12 months, then you can accept that documentation to serve as your first step for skin testing. You would still need to do a second step and on time of hire, and that would be considered the 2 steps. So remember, I talked a little bit earlier about when is a chest x-ray necessary. So for the first time, you've noticed that someone has had a reactive skin or blood test. So they've tested positive, and this is the first time to that patient or employee's knowledge that they've ever been positive. So you got it, that test is only determining that they have infection. We need to see inside those lungs, or you do, and see what's happening if there's some abnormalities. Also, you got to do a risk assessment. Anytime that you do testing, whether it's skin test or blood testing, you want to do that risk assessment. That should be done annually on everyone, all of your employees, because risk can change from year to year. There may be an exposure. They may have traveled. They may have had family who traveled and then came back. And so you want to see what that risk year to year is on your employee, and that will also determine whether further testing, if they potentially work in an area that's not being annually tested, that risk assessment will tell you that person needs to be tested this year. And of course, always it trumps everything. If that individual has any signs and symptoms, they need to be tested and need a chest x-ray. When not to perform a chest x-ray, you're never going to do a chest x-ray in lieu of either skin or blood assay testing. It does not take the place. Chest x-rays do not indicate that there's infection for TB in that person's body. So we need to do that initial testing first to see if there is infection present, and then the chest x-ray to see if there's any changes in the lungs to indicate that there may be some active disease. And then of course the next step would be sputum collection, and that's handled by in airborne infection isolation always. What must be documented for your control plan? All of those test results. If they have had a past previous positive, again, if they're new hire, you need to have documentation of that. If you don't get documentation, you start testing like they've never been tested before. All of your annual test results and those risk assessments. How far back can you accept a previous skin or blood assay test result? Again, I went over that just a couple of slides earlier. If it's been less than 3 months, they don't need a new test. If it's been greater than 3 months, less than 11 months, meaning less than 12 months, because you're going to test always that 1-year anniversary, they only need one test result. If it's greater than 11 months, that's when you're going to do your 2-step skin test or the 1 blood assay. Sometimes I recommend printing this slide up and placing that somewhere up in your exam rooms or offices so that you can remember. It's a good helpful hint. And yes, you can accept those other results from another facility. And again, it's just quoting those sections that I just mentioned. Are all healthcare workers required to have annual testing? We're still getting this question across the state. And why is that? Because there's turnover in every healthcare facility. We know that. So no, not everyone needs to be tested. You know, in 2019, CDC brought out that new recommendation because we do such a great job in healthcare. We're all masking, we're all taking precautions, we're getting patients in AII, airborne infection isolation, pretty quickly. And so we do not have those high incidents anymore of healthcare workers getting active transmission and showing active cases. So by doing that, it's not necessary for everyone to be tested annually. However, like I said, if those individuals are working in areas of greatest risk for exposure, then yes, they need to be added into your infection control plan and tested annually. And that's what I just mentioned there. Or if they have a newly identified risk. So switch gears just a moment and talk a little bit more about contact investigation. We call it CI for short, but your local health department, and for you all, Louisville Metro, they will be in charge basically of that whole entire investigation, whether the patient is inpatient still or they've gone home and been discharged or discharged to another facility even. Local health departments and state health departments in other jurisdictions. For instance, you have our neighbors across the river in Indiana and Illinois. Those states will be leading the contact investigation. So that's why I said it's very early. As soon as you have someone that's suspected of TB, you need to be reporting that individual, that patient, within 1 business day to the local health department in Louisville Metro. They have to turn around and notify us, the State Department, within 1 business day. And all of that is so that they can start testing the home and the closest individuals to that patient to see if there's been any transmission. So if we have a patient that's just being suspected, we don't even start contact investigation at that point. It's when they're highly, highly suspicious, and we pretty much know and anticipate that we're going to have some positive results, whether it's from a gene expert or culture. But we don't wait for contact investigation for 6 weeks to grow out. If it's highly suspicious, we're going ahead and having our local health departments test those close contacts. Now, we will, those health departments will help guide your IPs to determining when employee health needs to start testing those employees that have been exposed. Okay. And this slide can be a little misleading on that, and I apologize. We'll probably need to fix this slide a little bit. But they'll be tested initially when your local health department says, yes, we have indicated that close contacts or home contacts, there has been some transmission. And so now we know that how infectious that person was. Also, we've got sputum smears back, so we're looking at that. And so it's a good idea to go ahead and start testing those employees that have been exposed. And who would you test first? Anyone that has any immunocompromising diseases that they need, or conditions that they would be of greatest risk. And then repeat testing would be 8 to 10 weeks. Okay, because remember, I said it can take 8 to 10 weeks for an individual to mount uh, a reaction to one of those tests. You are going to have to report to the health department all the individuals that were tested, a total number. Did you test 20? You do not need to share their actual names, but you need to share some type of communication, whether it be a spreadsheet of their initials or some identifier that the health department could then easily communicate back to the IP or employee health of who individuals needed to be retested or for whatever reason. So there needs to be some type of identifier, but if you're not comfortable using the actual employee's name, that's fine. Because why is it? We have to report to CDC all contacts to cases that have been tested and what the results are. And that is real time. So there's turnaround times that our local health departments have to have in getting that information into those reportable formats that go directly to CDC. Because once they see that we have an active case, they want to start seeing those contacts. And if they do not start seeing that those contacts have been entered into the system, then they're calling me and making sure that contact investigation has actually been done. Okay. And remember, this is HIPAA compliant. So you don't have to have that patient's consent before sending all of that information. And again, your local health department, Louisville Metro Health Department, will guide you in what information that they actually need regarding your internal contact investigation. All right, we're going to touch base here a little bit on when can a patient be released from airborne infection isolation. Okay, am I going okay on time?
I think we're a little over on time, but if
Okay,
people are willing to, if they want to stay on and you would like to continue, that is fine. And if not,
okay.
then we can continue the recording and people can go back, or we can set up a different time. So
Sounds good. Sounds good. I can go on and you all can cut me off. I've just got a few more little slides, but I think, Julia, you're going to get the information out that we're going to have some other opportunities, right? So anybody that needs to leave, please go ahead. We want you to get back to your normal duties. So when can we release from airborne infection isolation? And I've got the MMWR reference here for you. And we usually will say, look at the decision outline on page 9, box 3. But while in the hospital for any reason, patients with pulmonary TB or suspected of pulmonary TB, or it's being ruled out, should remain in airborne infection isolation until they are receiving standard multi-drug anti-TB therapy. Now, those are the individuals that there's been a decision to start medication. Then they have just demonstrated clinical improvement, and they've had 3 consecutive AFB negative smear results of sputum specimens collected 8 to 24 hours apart, with at least one being an early morning specimen. Now, we've had questions if a bronch specimen can be one of those 3, and yes, absolutely, or more specimens. Of course, induced specimens also. Always check with your local health department prior to releasing patients to home isolation. We don't want patients going home and the health department does not know, and they've been home 3 or 4 days, and they've gone out and gone to Walmart, Kroger, they've gone to church, school, work, and they should have been remaining on home isolation. So anytime you're discharging someone from AII directly to home, because they still can be on home isolation. You can release to home isolation. Make sure Louisville Metro Health Department knows about that so that they can quickly get to that patient's home and start doing training and education to the patient and family and continue those medications. Hospitalized patients returning to a congregate setting, that's any shelter, any detention facility, or long-term care, they have to have, before they can be released back, discharged back to those congregate settings, they must have 3 consecutive AFB negative smear results, and they must be 8 to 24 hours apart. So you can have the smear results, 3 negatives, or you can have 2 negative gene expert results. Okay, so I'll say that again. To go to a congregate setting, to be discharged to a congregate setting, whether they're active TB or they had been suspected and ruling out of TB, to go to those facilities, we have other regulations that state they can't accept that patient for the first time admit or readmission unless there have been at least 3 negative consecutive smear results or 2 negative consecutive PCR results. So very, very important. Awareness, we have a biannual newsletter. That's where we try to keep you all up to date. So we have connections to the infectious disease and infection control listservs at the state office, and we send that newsletter out to everyone. If you're not a part of that listserv, please let me know and we will get you on that listserv. But that's where we give important updates. We usually also have an annual update. We have our experts at Southeastern National TB Center. So we, from time to time, we have our own office hours monthly, the third Thursday at 2 o'clock every month, except for usually December and January. But we have different topics, and we will also send out those calendars in the beginning of the year to let you know those dates. And then we will also house our calendar on our website. So remember, always isolate your patient and collect those sputum before giving any medications. Help guide your providers. They may not be aware of that. We want to get sputum. We want to see if there's any resistance. We want that PCR gene expert, preferably, to see if there's any rifampin resistance before we give any meds. And we've got a motto: get those bugs before you give the drugs. We make sure that our laboratories are sending an isolate when there is a positive culture, or a direct specimen to the state lab if you do not have a gene expert, but I believe you all do. Make sure your in-house pharmacists are compliant with reporting also when they are prescribing 2 or more anti-TB drug medications. And who do they report to? The local health department. Always report that any suspected or confirmed active TB case has been reported to the local health department within 1 business day. You all do a great job in communicating those suspected individuals. So keep doing that. We don't want to wait for confirmation before you report. And then also comply with your annual TB testing and screening requirements. Again, you all do a great job. And we don't need everyone testing. There just isn't a need anymore for that. It's a waste of time and energy, but resources. And we want you to concentrate on those areas and employees that have the highest, greatest risk for exposure. And avoid unnecessary chest x-ray. Just because they've had a previous positive at some point doesn't mean they get an annual chest x-ray every year. We don't even do that anymore. CDC says it's unnecessary. Your risk assessment, that's your individual risk assessment, is what drives the need for testing and a chest x-ray. Okay. Don't forget, update your control plans. Make sure that you've noted who needs annual testing. Also, monkeypox, there is still a rise. So I've got this in here. You can give that vaccine on same day of TB testing, or delay TB testing for at least 4 weeks if you're giving that vaccine not on the same day as you're doing TB testing. Don't forget, any signs and symptoms of TB disease, all tests and exams should be pursued without delay, regardless of the vaccination, okay? Get the bugs before you give the drugs. All right, and here's our contact information. Thank you all so much. It really is a pleasure to be here. And Julia, you want to get some more of that information about next month?
Yeah, so just really quick, there were a couple of comments in the
Oh,
chat.
sure.
So one comment was around people who took the BCG vaccine overseas
Yeah,
are most likely going to have a false positive skin test. So I think that was just
absolutely.
highlighting
Absolutely.
purposeful testing
Yes.
approach.
Even more so the reason to do the risk assessment, because you're going to identify those individuals that are non-US born. And again, you would not even do a skin test on those individuals, because sometimes those individuals don't even know what vaccines they got as a child and are unaware that the BCG vaccine was given to them. So it's best to just skip skin tests altogether for non-US born, regardless of where they were born.
Perfect, thank you. And there was another question. Does reporting go to the Kentucky Health Department and Louisville Metro Health Department, or the local health department, or to the patient's home resident county, or all three? So for example, a patient lives in Bullitt County, the test was collected in Jefferson County, and then it needs to be reported to the state.
Absolutely, great question. So technically, you're reporting to Jefferson County, okay? And Jefferson County, you should be telling them at Louisville Metro Health Department what county of residence that patient's in, and they will be notifying that county. However, if you reach out to both, that's perfectly fine too. But we're just trying to save a little trouble and you not having to reach out to those other counties. Again, the local health department can take on that responsibility for you all reaching out to Bullitt or Clark County, just wherever someone would be their jurisdiction. And that's particularly important if it's out of state. So we want to minimize that chain of communication as much as possible and not put so much burden on the hospital employees. Also, most states prefer state to state reporting, state program to state program. So again, that's why it's best to always report to Jefferson County or Louisville Metro Health Department, Public and Health and Wellness, and they'll take care of it from there for you. But it's important to let them know what county of resident or state that patient is.
Okay,
Great question.
And that holds true for all counties across the state. So if I work in Owensboro and the patient resides in a different county,
Yes,
it still works the same. Perfect.
it works the same. Yes.
Great. There was also a question about whether or not when this recording would be available. So all of our Grand Round recordings are available on our YouTube channel. And then to Emily's point, we are on November the 19th. Gonna have at our office hours, our colleagues from the health department, Emily and her team, will be at our office hours to be able to answer some of those other questions that we know that you're going to think of when you either get off the phone, or just some clarifying questions or issues that you've maybe experienced that it would be a benefit to go directly to the expert on. So mark your calendar for that. So that's November the 19th from 12 p to 1 p. That's Eastern time. We'll send out more information about that. It'll be on our website and in our newsletter, but I just wanted to let everyone know. Does anybody else have any other questions? All right. If there's no other questions, thank you very much, Emily and Ashley, for doing this presentation for us. And I hope that everybody has a wonderful rest of your day.
Thanks, everyone. Bye. Thanks, Julia,
Bye.
so much.
Thank you.